Hello, my name is Donna Martonik. Welcome to my DNP project presentation titled Reducing Rapid Response Activations by Screening for Obstructive Sleep Apnea, a Single Center Experience. I was assisted in this project by Dr. Charlene Myers, my faculty advisor, Dr. Charles Sunday, my DNP preceptor, and Dr. Christopher Alia, my physician advisor. Obstructive sleep apnea is estimated to affect between 4 and 6 million people. However, nearly 90% are undiagnosed. The significance of undiagnosed obstructive sleep apnea prompted the inclusion of identifying patients with sleep disordered breathing as part of the Healthy People 2020 initiatives. Additionally, the Joint Commission has also published a safety advisory suggesting that patients admitted to acute care facilities should be screened for obstructive sleep apnea as part of the admission process. These guidelines have been issued because there is a clear link between obstructive sleep apnea and cardiovascular diseases such as congestive heart failure, resistant hypertension, and cerebral vascular disease. Recently, there is a growing body of evidence that suggests identifying patients at high risk of obstructive sleep apnea in the acute care setting is feasible and that preemptive treatment with positive airway pressure support during hospitalization offers additional treatment benefits. Prior to the initiation of the project, a needs assessment was undertaken. As part of this process, the census data for the Lehigh Valley was explored, which revealed 47% of the population are of Hispanic origin. This is significant because evidence suggests that Hispanic patients may be at higher risk for obstructive sleep apnea and are often diagnosed later in the disease process. The hospital is a 150-bed multi-specialty facility with an average of approximately 750 medical admissions through the emergency department each month. The rapid response team is made up of 8 nurse practitioners who cover the hospital 24 hours a day, 7 days per week. This group averages 75 plus rapid response team activations or resource utilizations per month. Prior to this project, screening was not routinely done, but a data analysis in the 3 months prior to the project's initiation suggested that 35% of the rapid response team activations occurred in patients with a BMI greater than 35, suggesting that a large number may have had undiagnosed obstructive sleep apnea. The overarching aim of the project was to identify through screening medically admitted adult patients at high risk for obstructive sleep apnea. Patients at highest risk would then be preemptively treated with positive airway pressure support. Patients who refused positive airway pressure support, did not wear the appliance for 4 or more hours, would also be followed during hospitalization. The goal of preemptive treatment was to determine if this measure would help reduce rapid response team activations and/or resource utilization. Patients would be screened using the snoring, tiredness, observed apnea, pressure, BMI, age, neck size, and gender, abbreviated stop-bang questionnaire. This is a well-validated tool that assigns a risk category based on answers to 4 subjective questions combined with 4 objective assessment parameters. Patients are then either high risk, which equates to approximately a 75% likelihood of having obstructive sleep apnea, moderate risk, or low risk. All medically admitted patients greater than age 18 were eligible to be screened. The exclusion criteria included a pre-existing diagnosis of obstructive sleep apnea, inability of the patient or a reliable spokesperson to answer questions to the stop-bang questionnaire, nocturnal positive airway pressure support or oxygen at night prior to admission, or the patient refused to participate. Screening for obstructive sleep apnea using the stop-bang occurred 24 hours a day, 7 days per week. The stop-bang questionnaires were placed in several locations throughout the emergency department and in the hospitalist office to make it easy for clinicians to fill out the forms. The completed forms were left and collected at the end of each shift. If the patient was found to be at high risk, a consult was generated to the pulmonary team, and the patients were ordered overnight pulse oximetry and positive airway pressure support. Demographic data, risk category, positive airway pressure support application and compliance, rapid response team activations, unintended ICU transfers, respiratory decompensation, new onset arrhythmia were all manually entered and coded into an SPSS data file. This information was recorded using the patient's medical record number in a password-protected laptop to help protect the security of the data. Outcome data was prospectively and retrospectively extracted for each patient by viewing the information in their electronic health record. This information was then entered into the SPSS file. Follow-up appointments were also tracked for high-risk patients. There are several significant results to report. A total of 159 patients were screened during the 2.5-month study period. This represented approximately 26% of all medical admissions during this time frame. There were 58 high-risk patients, 33 moderate risk, and 68 low-risk patients respectively. Combined, high-risk and moderate-risk patients accounted for more than 50% of all patients screened. As previously mentioned, high-risk patients were evaluated by the pulmonary service. In total, 42 patients were seen. 13 patients were compliant with positive airway pressure support, which was defined as wearing the appliance for more than 4 hours overnight. Data was collected related to rapid response team activations, new onset arrhythmia development, respiratory decompensation, and unintended ICU transfers. Rapid response team activations were significantly reduced in the pressure support treated group with a p-value of less than 0.05. Additionally, unintended ICU transfers were also reduced in the PAP treated group with a p-value of less than 0.05. Though moving towards significance, the p-value was not less than 0.05 in the PAP treated versus untreated patients regarding respiratory decompensation and new onset arrhythmia development. Nocturnal hypertension is thought to be a contributing factor in the pathogenesis of resistant hypertension and the development of cardiovascular consequences in obstructive sleep apnea patients. The rapid response team members receive approximately 40 calls per month related to nocturnal hypertension, prompting its inclusion as an outcome measure. Nocturnal hypertension was common among the high-risk patients that were screened in this institution, equating to 85% of these patients. A one-way ANOVA was performed comparing patients treated with positive airway pressure support and those that were not in terms of the incidence of nocturnal hypertension. Though moving towards significance, positive airway pressure support did not reduce the incidence of nocturnal hypertension. There was a significant difference, however, between patients at high risk who had a mean incidence of nocturnal hypertension of 2.28 and low risk patients who had a mean incidence of hypertension of 1.4 with a p-value that was less than 0.05. Because increased length of stay is often associated with complications during hospitalization, I examined length of stay data between high-risk and low-risk patients. The mean length of stay for high-risk patients was 4.7 days. The mean length of stay for low-risk patients was 3.7 days. Though not statistically significant, it should be noted that patients at high risk for obstructive sleep apnea had on average an increase of 1 full day in length of stay. Future studies should examine this phenomenon in more detail. Lastly, all high-risk patients were offered follow-up appointments with a sleep medicine professional for definitive obstructive sleep apnea testing and management. As of this date, 37 patients have been scheduled. Several have already undergone overnight sleep studies and are being treated as outpatients. This project builds on the growing body of evidence that suggests screening for obstructive sleep apnea in the acute care setting identifies a significant number of high-risk individuals. This project also suggests that preemptive treatment does offer benefits in terms of reducing rapid response team activations and resource utilization. Additionally, this project raises awareness of the connection between high-risk obstructive sleep apnea patients and nocturnal hypertension. Previous studies in the literature report nocturnal hypertension in 85% of patients who were seen in an outpatient sleep medicine clinic. To my knowledge, this was one of the first projects to look at nocturnal hypertension in relation to high-risk obstructive sleep apnea patients in the acute care setting. Lastly, it is important to examine the cost associated with this project. Capital cost in relation to positive airway pressure support devices and overnight recording pulse oximetry equipment was equivalent to $4,200 for the 10-week study period. There was revenue generation, however. 42 pulmonary consults were performed at approximately $92 per consult, which was equivalent to $3,864. Additionally, there were 37 outpatient follow-ups at approximately $114 per visit, which was equivalent to $4,218. Patients who underwent overnight sleep studies as an outpatient, the interpretation of those studies is equivalent to approximately $800 per study for a total of $29,600. In terms of decreasing disease severity, currently we spend more than $30 billion a year on the treatment of congestive heart failure alone. Identifying patients at high risk of congestive heart failure by treating them for obstructive sleep apnea could substantially reduce that number. More research is needed to explore obstructive sleep apnea and nocturnal hypertension in the acute care setting. As a result of this project, the health network where the project took place is currently looking to expand screening for obstructive sleep apnea and preemptive treatment as a means of reducing complications in high-risk individuals. In conclusion, the project was successful in identifying a significant number of patients at high risk of obstructive sleep apnea, which was a major goal. Preemptive treatment with positive airway pressure support did reduce rapid response team activations and unintended ICU transfers, but did not meet statistical significance in reducing nocturnal hypertension, which often leads to increased resource utilization. Despite this, the project raises awareness of the link between high-risk obstructive sleep apnea and nocturnal hypertension, which will require future investigation. Thank you all for your time and attention. Included here are key references that were instrumental in guiding this project. Have a great day.